So, as Ben introduced me there, I'm Michael Coffey. I'm a pediatric trainee in Northern Ireland, and I am going to be taking the pro side of this debate, and I'm going to be trying to convince you this afternoon that critically ill children should be resuscitated using balanced solutions. So, what is a balanced solution? So, a balanced solution, they have sodium, they have potassium, chloride, content similar to that of extracellular fluid, and when given intravenously, have fewer adverse effects on the acid-base balance of the patient. So, if we were to imagine our ideal fluid, what would it actually include? So, if we're going to think about an ideal resuscitation fluid, it'd be a fluid that would remain in intravascular space for several hours. The chemical composition should be similar to that of extracellular fluid, and the constituents should be readily metabolized and excreted by the body. It should be safe, sterile, and not prone to cause allergic reactions and organ toxicity or other side effects. It should also be easy to transport, store, administer, and should be fairly reasonably priced. So we think about actually why we give our fluids. So we give our fluids for different reasons. Generally, we kind of give them for resuscitation, maintenance, replacement, and I'm focusing today mainly on in resuscitation scenarios. I also remember that in each case, in each individual patient, and different contexts, there's going to be different needs for what we're going to require. So there's no real one size fits all. So, if we actually have an ideal fluid, it actually doesn't exist, unfortunately. So if we think about what we do have, so here we've got three fairly common fluids that we'll see. So on the left, we have sodium chloride and normal saline. In the middle, that's plasmolite. And we got Hartmann's. So we look at these three. One is not like the others. So two of them are balanced solutions, and one of them is an unbalanced solution. And I'm going to try to convince you today that for the purpose of resuscitating critically unwell children, not to reach for the 0.9% saline, but instead go for a balanced solution such as plasmolite or Hartmann's. So we actually look at what's inside our fluids. So we said that a balanced solution is one that's closer in sort of sodium, potassium, and chloride content. So all three solutions are isotonic, but if we look at how they compare to plasma levels, you can see that the plasmolite and Hartmann's have sort of similar sodium and chloride to what's in plasma. Plasma has a little bit of magnesium and potassium. Hartmann's a little bit of potassium and chloride. And then between plasmolite and Hartmann's, they've got a little bit of buffering solution as well. Whereas the sodium chloride just has what it says in the tin. It's just got sodium and chloride. So even though we call it normal saline, I think we should really emphasize that it is very much not normal. It's very much not physiological in how it acts. There is 1.5 times more chloride and 10% more saline in our normal saline than what is in plasma. So essentially that's the issue basically. So why is that an issue if we have all this extra sodium and chloride? So essentially, whilst there's even amounts of them, when we give them into the patient, those sort of distribute unevenly, and actually the chloride is just far higher levels superphysiologically, and it acts asymmetrically and causes a hyperchloremic acidosis. So if you look at this slide here, that's sort of showing that in terms of when we look at the acid base levels, what impacts the acidosis or alkalosis level in the body is our cations and our anions and basically the difference between them. So if we were to massively increase our anion level, for example, by giving a big amount of chloride, that's going to drop our pH. And if we did the inverse, that's going to increase your pH. So you see at the bottom there, that's what happens when we give saline. We're going to massively increase the chloride and decrease the pH and causing acidosis. Again, that's just showing how these different fluids affect the body. So if we give our normal saline, we're increasing the sodium, massively increasing the chloride, and causing a drop in pH. Whereas like a balanced crystalloid along the bottom, we're not going to affect the sodium chloride too much. We might have a little bit of an alkalotic effect. And then if we compare it to like a Hartmann's in the bottom left, we shouldn't really affect the pH at all, actually. So we go a bit into the history of these fluids and how we kind of got to where we are. So basically in the 1830s, in response to the cholera pandemic, we have two doctors in Scotland, that is William Shaughnessy and Thomas Latta. They are the first doctors to sort of formulate and use salt solutions for treating these incredibly dehydrated patients with cholera. And they recorded that in sort of landmark papers in the Lancet. Then it seems to go out of vogue for a little while, with varying difference in makeups of these sort of salt solutions until we get to 1888 with this man, Hartog Hamburger, and he created what's our current 0.9% saline through experiments in different amphibians and mammals and finding what sort of solutions was able to keep different anatomical aspects alive in the lab through in vitro studies. It's then unclear actually how we go from these in vitro studies to the sort of widespread use and how sort of normal saline got so popular. Likely it's due to the how it eases manufacturing and low cost of it. But if it went through a clinical trial, and we have this quote here from Professor Dilip Lobo, who's a sort of expert in fluids and fluid balance. But if it had been tried to be pushed onto the market now, it'd be unlikely that saline wouldn't pass if he has one trial. So what are the issues of 0.9% saline? So we know that it causes acidosis, that we chatted about, and the acidosis causes a hypochloremic metabolic acidosis. So why is that a problem? Well, we know that acidosis has negative effects on inotropy, has an impaired response to catecholamines, increases your respiratory drive, and has other negative effects as well. We also know that acidosis is part of the lethal triad in trauma, so definitely it's worth avoiding in the resuscitated trauma patient. We know that the hyperchloremia pushes potassium out of cells, so it causes hyperkalemia, which is an effect we don't want. And we also know there's an associated number of adverse clinical symptoms, such as abdominal pain, abdominal distension, nausea, vomiting, and drowsiness. There's also a few different adverse events that are associated with this acidosis, such as increased need for blood transfusions and bicarbonate infusions, increased length of hospital stays, and increased coagulopathy. We also know that there's evidence to suggest that saline affects the renal hemodynamics with decreased renal blood flow velocity and perfusion when compared with balanced solutions. And there's an association with increased need for renal replacement therapy, increased AKI, and long-term renal dysfunction. Different animal human studies showing that there is an increased amount of pro-inflammatory states associated with saline compared with balanced solutions with increased cytokines and different consequences from those. And most importantly, there's also a suggestion of association of increased mortality when comparing saline versus balanced solutions.
2 minutes, Michael.
Okay. So yeah, I guess that's the most important thing is that there's an increase in mortality, and especially in sort of SIRS and septic patients. So whilst this is, there's still a lot of evidence to be found out about these, but there's the evidence base is growing in terms that the balanced solutions are better than saline. So that's all very theoretical. So as we go into an actual case, so here's an example that you might potentially see as to why balanced solutions work better. This is an example of a patient who has presented to A&E with DKA, and you can see their first gas, they've got a severe DKA, quite a significant acidosis, and then we can see their second gas 4 hours later after they've had 2 boluses of saline. They've started on their insulin, they've started on their fluid, and clinically they're pretty well. The GCS is okay, their hemoglobin is stable. But actually, if we look at that second gas, it doesn't look like they've improved much at all. But if we kind of actually go back and look at what's happening at their different numbers, and I've actually used Chris's app here, you can kind of see that actually we've kind of treated their DKA quite a bit. And in fact, the chloride is making a big effect on this child looking worse than they are. And this is going to cause lots of concern. This child's probably going to end up in PICU when they maybe don't need to. So what are the benefits of balanced crystallized? Sort of more physiological. There's reduced acidosis, there's reduced mortality, reduced renal dysfunction, and faster resolution of DKA. So I guess why would we use saline? I suppose one use is for the patient with metabolic alkalosis, but otherwise the only reason I can see is that it's cheap, it's available, and it's what we usually, which isn't great reasons at all. In terms of other things that we used to do, so I'd show some examples. So these are this is a patient's notes. This is from 1997, so more historical notes. This is actually my own personal notes. And you see on the right here, you see I've been resuscitated with a fluid. It's called HPPF. That's actually a colloid, human plasma protein factor. You can see on the left, I'm given fifth normal saline, and it's actually so embedded in practice that it's actually printed onto the old anesthetic charts. Certainly, in my career as a pediatrician, I've never seen either of these fluids used, and certainly if I tried to prescribe fifth normal saline in Belfast, I'd probably be thrown out of the building. So
Michael,
just because we've always done this way,
coming to a close, so if I can ask you to draw to a close, if that's okay.
Yeah, so I suppose just because we've always done it this way doesn't mean we should keep doing it this way. IV fluids are a drug. It's important that any use of drug, we have to think about what we're doing, and we must be aware of the consequences of what we've given. So we really want to be given balanced physiological solutions. I feel that's sort of reasonable and pragmatic in the resuscitation of the critically ill child.
So my name is Peter McAllister. I'm a paediatric reg, currently working in Belfast, as Ben said, and work in the paediatric emergency department. So a lot of my focus is more on management of critically unwell children in the emergency department. And I hope, based on this 10-minute presentation or so, we'll give you a bit of a flavour and anecdote, a bit of a journey as to why I think critically unwell children shouldn't be resuscitated using balanced solutions. I want to start off with a bit of a story, first of all. So I want to tell you about Black Heart. So Black Heart is a new stout. Why am I talking about stout on a paediatric emergencies conference? But hopefully gives you a bit of an idea as to the argument. So it's a new stout produced by a Scottish beer company called Brewdog, and essentially it's direct competition for a long-standing Irish stout, as in Guinness. And they're very clever in their marketing, because their whole marketing slogan, the whole way for people to buy their product is, "What if it's better?" And very clever, because automatically, for people who have had Guinness, you were like, "Oh, well, what if something is better than Guinness?" And I've tried both, and I can tell you that I will continue to drink Guinness, and I hope that gives you a bit of a flavour for the rest of this presentation. As Michael said, saline has been around for many, many, many years, since 1831 during the cholera epidemic in Europe. And I think that's an important point, that there have been other solutions, as Michael has talked about, that have come around even from the 1880s, such as Ringer's lactate and Hartmann's and things. But regardless of all of that, saline has stayed, despite all of the kind of evidence that has come out since, and despite all of the other fluids that have been tried and tested, and despite all of the innovations in medicine over the last 200 years, and all of the innovations that have happened, that saline is still here, and is still alive and kicking. And I think it's an important point to kind of highlight about the historical preference with regards to saline, that it's important, and it's important for lots of different reasons. In the emergency department, when you've got a critically unwell child in front of you, you're and as a senior person within that, you're managing the room. So you could have foundation doctors in front of you, you could have GP trainees, you could have pediatric trainees, emergency medicine trainees, junior nurses, senior nurses. You have a wide range of people in the room, and it's important that you're using something that you're familiar and comfortable with. And I kind of liken it to getting home after a busy day's work and getting your slippers and your hot chocolate. That it's something that you want the whole room to be comfortable with. And there's a huge amount of human factors with regards to the resuscitation of a critically unwell child. That, yes, the management of a critically unwell child in an intensive care environment is slightly different, but in a resus room, in a district general hospital, or in a tertiary centre, the resus is very different. And you need to know your room, and need to be comfortable, that everybody's comfortable with what you're doing with regards to the management of that unwell child. And it's not just me that kind of thinks this. Did a survey of paediatric trainees in Northern Ireland with regards to the choice of saline versus balanced solutions. And you can see it's pretty close as to what the preferred solution is, that regardless, despite all of the arguments, despite all of the supposed evidence, that saline is still the preferred choice in paediatric trainees in Northern Ireland. And the confidence levels with regards to prescribing balanced solutions over saline just really isn't there, that saline is still the fluid that we are taught about, we're most comfortable with, and we know the effects of it. But regardless of that, we continue to use saline, and we should continue to do so as well. So kind of liken this as well to saline, the use of saline to hopefully some of you recognize this as the cornerstone, which is the most important brick in any building. It's the kind of foundation of where the building is built on. It carries a lot of the weight, and saline is kind of carried that weight for pediatric emergency medicine over the last many years, and is used widespread within pediatrics in terms of the resuscitation of critically unwell children. We'll discuss some of these here. So, Michael had touched on some of these. We've already touched, obviously, on the historical preference for saline, that despite all of these solutions, Ringer's lactate, Hartmann's have been there for over 150 years almost, and regardless of that, saline is still the most used fluid with regards to resuscitating the critically unwell child worldwide. It's universally available, easily used, people know how to use it, and it's really compatible with drugs, with no concerns about the potential interactions with medications that there would be with regards to using balanced solutions such as Plasmolite. It's also cheaper, almost half the cost. And the main point, which I'll touch on now, with regards to the literature, is there's a lack of definite benefit for alternatives. That there may well be this scientific thought with regards to the electrolyte balance, with regards to balanced solutions versus saline, but is there strong evidence, compelling evidence to say otherwise? And I would suggest no. So it's important when you're in a stressful situation resuscitating the critically unwell child that you can rely on your guidelines to manage this child in front of you. And I like that you touched on the fact that about the DKA protocol, that the DKA protocol by BSPED in the UK actually mentions about balanced solutions and says that the evidence base is not there for them to be used in DKA, and with regards to that, saline should still be used as preference. It's still widely used with regards to sepsis guidelines throughout the UK. It's the only fluid with regards to the management of fluid resuscitation in neonatal patients, and it's also the mainstay of fluid for managing critically unwell metabolic patients. And these are just a flavour of some of the guidelines that are used, and it's also widely used in many, many other guidelines with regards to the treatment of unwell children. And my last little anecdote before we go to what some of the evidence says, I want to tell you about this man. So this is man's called Andrea Pirlo, and I'll take you back to 2011. He plays for AC Milan in Italy, and he's 31 years old. And the thoughts are that he's done, he's finished, he's past his prime. And he signs in a free transfer to Juventus, one of AC Milan's biggest rivals. And for the next 3 years, Juventus win the league, and Andrea Pirlo is the best player in the league. He wins the best player in the league for the next 3 seasons. And I know there is a movement, especially in intensive care environments, that is this the end of saline? And I like that you mentioned about a couple of different solutions that have been tried before, Michael, that regardless of all of that, is this the end of saline? There's been many times where it's been tried previously, but saline is still standing, and I imagine that it will continue to stand regardless that saline is not done. So what does the evidence say? So this comes from obviously a common cause of critically unwell children is sepsis, and this comes from the Surviving Sepsis Guidelines. And just want to focus on some of the language that they use. That yes, they advise the use of balanced or buffered crystalloids over saline, but it's weak recommendation with a very low quality of evidence. And if you're in the middle of a resus and you're managing a critically unwell child, do you want to be relying on the literature that says may, probably, generally, or indirect evidence? I would suggest no. And until there's compelling evidence to say otherwise, yes, a lot of the information with regards to slight increased risk of AKI and mortality is not significantly so, and it also largely comes from adult studies. So if you're suggesting that adults are children or small adults, then fair enough. But I think we'll come to in a second a randomized controlled trial that looks at this question specifically. And what does the manufacturer say about their own product? The safety and effectiveness of Plasmolite in children has not been well established by adequate and well-controlled trials. There's risk of side effects with regards to, there's numerous contraindications with regards to Plasmolite, and not indicated for the primary treatment of severe metabolic acidosis, and which is interesting because obviously critically unwell children always have a normal pH, so it's good to have all of these other things in your head with regards to the use of Plasmolite in managing a critically unwell child. Whereas we know saline, we know saline, we know the effects of it, and we should continue to use it. as mentioned, a lot of this comes from adult studies, but there are also adult studies which contraindicate what Michael had touched on with regards to the effect of buffered solutions in an adult environment. So if we're there's always a study that contraindicates that, and this is a randomized controlled trial where balanced solutions did not reduce the risk of AKI in comparison to saline. And when we looked at a retrospective cohort study using balanced solutions such as like Ringer's lactate in comparison to normal saline for pediatric sepsis, again, there was not associated with improved outcomes. And just one more paper before I bring this to a close, a systematic review in 2022 showed, yes, there's some evidence, again, not significantly so, but some evidence of improvement in blood pH and bicarb when using balanced solutions versus unbalanced solutions. But what is the actual clinical benefit of this? Does this actually make a difference to the journey of that unwell child? Does it impact on their mortality or morbidity? And the evidence is really out with regards to that at present. So I think this hopefully will draw everything to a close, and will hopefully summarize everything perfectly and kind of makes my argument for me, to be honest. This comes from the Prompt Bolus study, which is currently ongoing. It's a randomized controlled trial looking at balance versus normal saline with regards to the management of pediatric sepsis. And I'm going to read it out because I think it's really important, and it kind of summarizes everything with regards to what I'm trying to argue for. That currently there is insufficient evidence to support one crystalloid fluid type for pediatric shock resuscitation, which was acknowledged as a key knowledge gap by the 2020 Surviving Sepsis Campaign guidelines. So the fact that we've used saline for a long, long time, there's not compelling evidence in pediatric population to suggest that we should stop using it. So why should we? And if Prompt Bolus tells us otherwise, then fair enough. But until that point, I would argue that we should continue to use saline as our main resuscitative fluid. So to draw everything to a close, I want you to take these things home with you and remember them. Remember Black Heart and what if it's not better? Remember to put your slippers on and be comfortable with using saline as we are. That saline really is the cornerstone of our management of critically unwell children. And is saline finished? I would argue no. And until there's compelling evidence from a randomized controlled trial, for example, to suggest otherwise, then we should continue to use saline as our main resuscitative fluid for critically unwell children.
Perfect. Thank you very much, Peter. Okay, so I'm going to give Peter and Michael 5 minutes to argue their case any further, pose each other any questions, and then we'll go to a vote. So Peter, Michael, over to you for 5 minutes to thrash it out.
Okay, so there was a few things there that Peter had said that I kind of would just disagree with a little bit. So, he said that saline's been around a lot longer than balanced solutions. I mean, saline's only around from 1888, whereas Hartmann's been around from 1889. So balanced solutions aren't just newly on the block. This is we haven't just imagined this. This isn't like, it's not, they've also been tried and tested through time. And plasma-light's been around since 1982. So again, whilst it's new kid on the block, only very, very, relatively, it's been well tested through time. It's, over 40 years old at this point. So like we're well experienced that it's safe as well. Like they're not trying to advocate for some experimental magic treatment here.
So I suppose that's a fair enough point, Michael, but I wonder why that hasn't translated then into guidelines if it's been around for 40 years, like Plasma-Light, and if other fluids, balanced solutions have been around for 150 years, not much more than saline, then why is that not translated into the kind of international agreed practice? Because if it was so significantly better, surely by now the guidelines would have changed. And even the fact the DKA guidelines, a perfect example, a common presentation of a critically unwell child, and they actually mention in the guideline that Plasma-Light shouldn't be used. So I just find that interesting. I think it's a fair argument. Yes, they've been around for a long time, but there's still not a compelling evidence to suggest that they're actually better than saline in the pediatric population, certainly.
I suppose I would say inertia is a big aspect of that. I mean, like you said, it's filtering in already. There's been a bit of traction towards it. I mean, the British Burns Association recommends giving Hartmann's, gift to sup and gift to hold. That's nice guidelines for adults in hospitals. Recommend avoiding saline, and like you said yourself, surviving sepsis, which is, I think, the biggest argument for resuscitating children, because our children don't come with nice diagnostic sides saying, I'm cardiac, I'm sepsis. We're probably all having sepsis in our mindset, and certainly the biggest evidence for mortality is in particularly a patient cohort with sepsis, And there's multiple, RCTs and different things that suggest that mortality is increased in even pediatric populations with sepsis. So I feel like,
Yeah.
and whilst there's differing reviews, there's nothing that suggests that balanced solutions are worse than saline.
And I think that's a fair point. If they're not worse, then you need to think about the other kind of effects. Cost is one. You need to counter for the cost is a really important one. If it's half the cost and doesn't have any significant difference, then why would you change essentially? Because it's going to be a cheaper solution that has similar effects essentially. We also need I think accounting for the people in the room is really important. Saline use is so widespread and so well used and so well known and so well taught, that without that compelling evidence to say that no, this is dangerous or this shouldn't be used, then why should practice with regards to managing critically ill children change? And I think having that in your head whenever you're managing a critically ill child, you want to be clear of mind. There seems to be a lot more to think about with regards to the choice of plasma-lyte, for example. There's other contraindications with regards to renal function and electrolytes and things. And I would argue that saline is a safer approach then with regards to not knowing anything about that critically unwell child, especially in the emergency department. So yes, I understand that the constituents of plasma-lyte may make a bit more sense, but until there's a study that totally answers that question, and maybe prompt bolus will be that study, then why should we drastically change our practice and the teaching that we've had since medical school?
The thing is that fluids are probably the most common intervention that patients get in hospital. So even if there's only a small improvement in mortality, that's literally millions of lives that you could save a year by like how many liters of fluids, how many thousands of liters do we prescribe individually, personally? And if there's even a slight improvement, I advocate that we should change. And probably just familiarity and comfort isn't a good enough reason for me to not try to improve my practice.
Yeah, and again, all good points. I wonder what the rate limiting step is then. If balanced solutions are so good and so great and so mighty, then why haven't they translated into practice? If they've been around for 150 years and plasma-lyte's been around for 50 years, then why are they still not recommending the use of plasma-lyte in children based on their own manufacturers? So there must be something that we're missing with regards to that, because it's not, as you say, it's not a new kid on the block. It's been around for many a year. Why are all guidelines not recommending this wonderful fluid with regards to management, with regards to management of critically unwell children? So I don't know what that issue is, but saline is safe and has been around for a long time, and will continue to do so. And there's been many other things that have tried to replace saline previously, and what's to say plasma-lyte won't be that.
Okay, so hopefully you're seeing the slide on the screen now. So go ahead and vote now. The guys are competing for this. It's the brand new McGrath Mac video laryngoscope. So absolutely amazing prize, and big thank you to Healthcare 21 for supplying it. It's the new upgraded version. I have a review on YouTube, so hopefully you did get a chance to check that out during one of the breaks. If you haven't, it's on the Paediatric Emergencies website. And this is an absolutely brilliant improvement over their last version. And I'm not just saying that because they've given me it for free. And I'm a little bit sad to give it away. It was such a great prize, but one of these guys is going to get a brilliant tool to improve their airway skills. So we'll just give it a little bit longer for the results to come in. I think things are slowing off there. So I think the answer is yes, critically ill children should be resuscitated using balanced solutions. So congratulations, Michael, you're the winner. And well done to Peter. I think he did an absolutely brilliant job of arguing that. I don't know how he was going to manage that, but he almost pulled it off.
We're about 6:05. Chris, do you want any time for discussion around that as a panel before we draw to a close? Or
I think if anybody has any strong feelings on it, I think it is worth mentioning.
I have lots of strong feelings, and I think the right decision was made. Can I dispel the myth, please, that balanced solutions worsen hyperkalemia? Because I was mentioned that electrolyte imbalances are a consideration, and it's a complete lie. Yes, balanced solutions have a bit of potassium in, but actually there's a number of reasons why they are not contraindicated in patients with hyperkalemia. And in fact, they're better choice than saline. Like we said earlier, hyperkalemia is made worse by acidosis. So you give a child acid, they're gonna get a bigger potassium surge into their extracellular space than they would otherwise do. Potassium concentration in Plasma-Lyte and in Hartmann's is much lower than what the serum concentration is to diagnose hyperkalemia. So you can't make anything more concentrated by giving a more dilute solution. And the biggest misconception is in children with lactemia. So the very sick children, we can't use Hartmann's or Ringer's lactate because it's got lactate in. And again, that's a massive myth, because the lactate gets metabolized into bicarb, which then makes the pH better. So it doesn't actually worsen the lactemia, it just neutralizes the pH. So I wanted to make sure everyone was on board with those three physiological phenomena.
And I was just going to say as well, the latest APLS guideline is very heavy in favour of balanced solutions. So that would have been a nice one if you managed to find that, Michael. I'm just going through updating the Paediatric Emergencies app, and I'm having to replace all the normal saline with Plasma-Lyte.